finira chechemekwe yango sedezi makile kuzina sana ya finira chechemekwe yango sedezi makile kuzina sana ya finira chechemekwe Bageri.
Happy Menstrual Hygiene Day, and welcome to Chiedza. Chiedza is a community
My first experience was I was very scared. Yeah, I was like, okay, what's happening to me? Yeah, it was very awkward for me, but I'd known about it already, so I actually expected it, yes. I was at school, so when I got home, I'm like, okay, what's happening? Then I spoke to my mom. She's like, no, man, that's nothing. It's what happens. She explained to me like the whole thing, what happens, and yeah, and then I got used to it. I think we should give more information about menstruation in schools, especially like from primary school, so like we can be able to be aware that things like this do happen and it is going to happen at some certain stage.
I got my first period when I was 12 years old. Do I think there's enough information? Yes, I think there is, because in schools there's life orientations and stuff, so a lot of students are being taught at school about the menstrual cycle. What do men know about periods? They don't know anything. I think they just know that women have got a menstrual cycle, but I don't think they understand, because it's not happening to them, it's happening to the women. But they do know that women do go through menstruations.
I get a lot of pains. They're very painful. I don't go to school when I'm on my periods at all. Being on periods, on menstruating, is not a choice. So women should be given like pads, maybe at hospitals. There should be like maybe at schools, kids, because there are some kids that they don't have money, because they're very expensive, trust me, and there are some kids that cannot afford to buy them. So I feel like maybe that's how they can support us women.
I have access to menstrual products. I wouldn't say that they are affordable. I've had situations where I couldn't afford that. And so I would love for the prices to be looked at worldwide. I think it's very important, knowing that as it's something that naturally happens to women all the time. I think that it should be made more accessible and more affordable for everybody. I talk about periods with my family and my partner. It's important, as we are not trying to, procreate anytime soon. So we are mindful of it with regards to safe zones or safe times, with regards to how it affects my mood, and in that way how it affects him.
When I was much younger, I never thought menstruation had to do with actual blood. I always thought it was something else, because I felt like blood would have been very absurd and unusual. An experience that will always be by me would be my first time, because I was home alone. My mom had traveled and it was just me, my dad and my brother, and I didn't know how I was supposed to tell them, so I just kept it to myself. The slang I often refer to it as is being on that level. It was influenced by my seniors in secondary school, because I often heard them saying, oh, I'm on that level, and I always wondered what they meant. But I finally got to understand what they meant by it. I envision a future whereby every girl has access to sanitary towels, because as advanced as the world is, some girls still don't have access to this.
I'm a rapper, entrepreneur, and philanthropist. And let's change the world.
We initiated a program called the Sanitary Bank Campaign, where we wanted to empower not only young women and young girls, but also young boys across the country. So far, we've distributed sanitary towels across the country to over 32,000 girls. Our idea is, how do we keep young teens in school, just changing the mindset of the society. We went to this village, we saw a girl who said she's not going to school because she's on a menses. The sad bit was that she did not have access to sanitary towels. And I ask myself, we are privileged and we have access to all these modern gadgets and phones, and we are in a world of skyscrapers and Wi-Fi. How comes we don't have access to sanitary towels? So I said, how can I transform and just change the world? Yeah, we did a walk from Nairobi, the capital city, to a town called Nakuru. It was, I think, 156 kilometers, where we were raising sanitary towels and awareness for just girls. It was a 6 days walk, and it was amazing. The experience was crazy. We had swollen legs. Guys got injured along the way. It was crazy, but the whole idea was the fact that it got coverage across the world, and the awareness. I think it changed the mindset as well. Yeah, I'm proud and I'm happy that we've learned so much along the way. We've interacted with girls and boys in different regions of the country, from the coast to the lakeside, to Nairobi, to the slums. And we've collected so many stories, and we're still collecting, and we're not stopping anytime soon. We want to reach the 100,000 target, move to 200 and 300 and 400,000. And until the day it becomes free to access sanitary towels, because it's not a women issue. I keep saying that it's a we issue. And power without impact is useless. I believe everyone has a say. Let's start there. Every single person in this world has a say. We have sisters, we have mothers, we have girlfriends, we have aunties. It means we're surrounded with women, because we coexist. The question is, how do we make the environment friendly for everyone?
Today is going to be a beautiful day, Manzi. We want to see smiles, we want to see happiness, we want to see experiences, we want to see moments, Manzi. And that's why we're doing this. We want to see impact.
And let's change the world. Thank you very much.
Wow, what a way to kick us off. That was King Kaka from Kenya. And we're back for the second day of the Africa Coalition Symposium on the Menstrual Health, brought to you by the African Coalition Menstrual Health Management and the UNFPA East and Southern Africa. I trust you all enjoyed yesterday. So many important conversations and so many new ideas. And I'm sure today is going to be even more food for thought. So please type in the chat and let us know your thoughts. So, let's begin with our first plenary session, integrating menstrual health into sexual and reproductive health policies and programs. And it's my great pleasure to hand over to a moderator for the session, Director of Social and Human Development, South African Development Community Secretariat, Dudu Simelane.
Good afternoon. Okay. Good afternoon to our audience, and welcome to this high-level plenary session this afternoon on day 2 of the symposium. I am Dudu Simelane, as has been introduced. I would like to give a highlight on the panel that we have here this afternoon. The panel session is titled Integrating Menstrual Health into Sexual and Reproductive Health Policies and Programs. The panel is divided into two parts. The first part will be to provide an overview and launch the new technical guidance on integrating menstrual health into SRHR. And the second part of the session will be to look at lessons learned from researchers. I also wish to acknowledge the following partners who have contributed towards the development of this session. That is the WHO, the African Union Commission, FEM International, the London School of Hygiene and Tropical Medicine, Menstrual Cup Coalition, Menstrual Health Hub, and PSI Europe. To set the scene for the panel discussion on the technical guidance on integrating menstrual health into SRHR, a video has been produced that provides a summary of the technical guidance. I will then request the technical team to play the video. Thank you.
Integration of menstrual health into sexual and reproductive health. For years, menstruation has been associated with shame, stigma, and distress. Yet menstruation is a natural biological process experienced by over half the world's population. That's why a growing global movement of activists, researchers, UN agencies, women and girls are working together to reposition menstruation as a key indicator for well-being. Echoing the ICPD Programme of Action's definition on SRHR, expert stakeholders from around the world have redefined menstrual health as a state of complete physical, mental, and social well-being, and not merely the absence of disease. Sexual and reproductive health and rights recognize that all individuals have the right to decide over their own bodies, to attain the highest possible standard of SRH, and to be free from violence and discrimination. Menstruation is fundamental to the fulfillment of these rights. When the human rights of all people who menstruate are met, they are more likely to experience menstruation and SRH in a safe, healthy, and dignified manner. UNFPA and partners are launching the new technical guide to support countries as they integrate menstrual health into their national policies and strategies. The guide recognizes the fundamental rights of all people who menstruate, including women and girls, persons with disabilities, transgender and non-binary persons, and women who are affected by humanitarian disasters. The technical guide will help countries and partners expand access to menstrual health services and commodities for all people who menstruate through integrating it into SRHR services by creating an enabling environment by ensuring that menstrual health is mainstream in relevant laws, policies, and strategies, advocating for menstrual health to be mainstreamed into universal health coverage to increase access to menstrual health products and services, ensuring that healthcare workers and community healthcare workers are trained to address menstrual health as part of a life cycle approach to SRH, family planning, maternal health, STI, HIV, and GBV services. Advocating to ensure that menstrual health products are included on the essential medicines list of countries. Integrating menstrual health into CSE, social and behavioral communication, and community mobilization programs. Strengthening research, monitoring, and promoting continuous learning through operational research. Integrating menstrual health into SRH will remove the shame, stigma, and distress and allow all persons who menstruate across the life cycle to fulfill their hopes, dreams, and futures with pride, dignity, and confidence.
Thank you. Thank you for the video. Great video there, and with very compelling messages for us to take away. I'd like to now introduce our panelists for this session. And I'd like to introduce Dr. Ian Askew. Thank you. Dr. Ian Askew is the Director of WHO's Department of Sexual Reproductive Health and Research and Director UNDP, UNFPA, WHO and World Bank Special Programs of Research, Development, and Research Training in Human Reproduction. I'd also then want to introduce Dr. Aneka Natsen. Thank you. Dr. Natsen is the Chief of Sexual and Reproductive Health Branch at the UNFPA. And if we have Dr. Gumi. Okay, we don't seem to have Dr. We do. Okay, thank you. Mm-hmm. Okay, thank you. And Dr. Njoki Ngumi is here. She is the Executive Director for Hiva Fund in Kenya. Thank you. So the panel, and welcome to the panel. Good to see you all on this panel. We will then proceed with the panel discussion. The first question to our panelists, and I'll explain who the question goes to. So this is the first question. The Menstrual Health Collective recently adopted a new definition of that menstrual health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in relation to the menstrual cycle. So Dr. Ian Askew, from the perspective of WHO and the co-sponsored Human Reproduction Program, why is this widely agreed upon definition for menstrual health important, and how can it steer action? Over to you, Dr. Askew.
Thank you very much indeed for the question, and it's great to be on this panel. From our perspective, the definition is an important departure from the past, in that it clearly signals that menstrual health is a public health issue with several dimensions, and it's not just about hygiene during the monthly period. In addition to the biological aspects, it also highlights the social and mental aspects of menstrual health. And importantly, it brings out the need for good menstrual health for full participation by all people in all spheres of life, including civil, cultural, economic, social, and political participation, free from exclusion, discrimination, and violence. The second point of departure for this definition is that it relates to the entire menstrual cycle and not solely the period of menstruation. This acknowledges that menstrual-related discomforts and disorders and the consequences for a person's mental well-being and social exclusion are not restricted to the menstrual period, but can occur across all stages of the menstrual cycle. It also acknowledges that although the majority of people who experience a menstrual cycle are women and girls, transgender and non-binary people may also experience menstrual cycles and so should be included in this area. Thirdly, the definition proposes some broad actions that are needed for achievement of the highest attainable standard of menstrual health. These include that make sure that people have access to accurate, timely, and age-appropriate information, that they can access and use materials, facilities, and services to care for their bodies during menstruation. They can access timely diagnosis, treatment, and care for menstrual cycle-related diseases and disorders, and that they can experience a positive and respectful environment in relation to the menstrual cycle, free from stigma and psychological distress. And fourthly, I'd just like to say that this definition has been developed by the Global Menstrual Collective Terminology Action Group, of which WHO is a member. So although this is not a formal definition of WHO, it is fully aligned with WHO's overall definitions of health and of sexual and reproductive health, and provides WHO with a very useful framework as we expand our work on this critically important yet often ignored aspect of health. So thank you.
Thank you. Thank you very much for your reflections, Dr. Askew. We'll move on, but before we move on to our next panelist, may I just request the audience to write your questions on the chat, and we will react to them at the end of the panel. If you could kindly also reference your question and direct it to any of the speakers directly and indicate who you're directing the question to, that would be very helpful when it comes to the answer session. So let's move on to Dr. Aneka Nathan from UNFPA. So the question is, from the UNFPA perspective, why is the definition important for SRHR policy and programs, in particular as UNFPA is the SRHR agency of the United Nations? So over to you, Dr. Nathan.
Thank you so much, and really happy to be on this panel. I was also part of the first Menstrual Health Management Symposium in, I think it was 2018. Now, as you said, to UNFPA as the agency for sexual and reproductive health, the most important thing is universal access to SRHR for all, in all their diversity. And that means that we also take very seriously the whole package, the whole span of elements that SRHR constitutes through the life course of a person. So this is about rights. It's really a human rights imperative to look at this more carefully and to have it fully included in SRHR. It's also a public health imperative. So it's about rights, but it's also about amplifying women's, girls, and other persons who go through a menstrual cycle to amplify their voices. And as Ian so eloquently, outlined, this is through the life. It is not just when you're having your menstrual cycle. It's about when you are young and want information, when you have your menstrual cycle, or if you don't get your menstrual cycle. And it's also about other types of bleeding. It's about women's menopause. It's a huge span of elements that we need to have a better way to put centrally in the package of SRHR. And it is about taking equal participation and women's equal right to be fully participating in society, in their families, in their societies, and at large. So, and as Ian said, it really changes menstruation from something that for centuries have been used as an excuse for the systemic discrimination of girls and women and others with a menstrual cycle. And it's made it's made people hide and be stigmatized. And it's also put a pressure on all of us that this is something you should just endure and try to figure out, and even be ridiculed for and excluded by. So the definition is a start. Through that, we have yet another platform for changing norms and enhancing rights. Secondly, it is an important entry point for information, services, and care to other SRHR interventions. And I would like to mention the importance of comprehensive sexuality education. That is really the platform for all other SRHR areas that people need information and services and care for. So it's a good way to have that as an entry point, to start talking about, to start educating and teaching people about their bodies, their bodily autonomy, their rights. And thirdly and lastly, it is an important part of the SDG Foundation for leaving no one behind. There are so many young people really left behind in so many ways. But then this, with having your menstruation or not knowing what's happening to you and being ridiculed in school, excludes you from so many parts of life. And we want to really amend that and really work together with women, young people, and all people that go through menstruation. Thank you.
Thank you, Dr. Natson, for your perspectives. You talked about rights, you talked about changing the perspective. I think this symposia are enabling us to do that, and the work that's already ongoing to change the norms. And then also, importantly, you have indicated leaving nobody behind. So thank you for that. And those are some of the key messages that are coming out from our panelists so far. So let's move on to the next question. Dr. Njoki, could you elaborate on how this new definition can assist civil society organizations in advancing menstrual health in the context of SRHR? Over to you.
Thank you so much for that. I'm really excited by this new definition, especially as regards focus on sociocultural norms and enhancing the public the negative women, particularly to men. It's really going to be important as regards framing discussions that we're able to have about men's, both the ideas around normal menses as well as the places where we have to enter in as medical personnel, where cycle.
Unfortunately, we have lost Njoki. Yes, yes, okay, we will wait for her to, she'll come on, we will wait. So Dr. Aneka, our second question to both you and Dr. Ian, let me ask Dr. Aneka to start first. So the question is, Dr. Aneka, the provision of people-centered integrated SRHR has long been an ambition of the international community. Can you briefly describe what is integration? And how will the integration of menstrual health into SRHR help to drive the menstrual health agenda forward? Dr. Aneka.
Thank you for that. And I think this is a question that, as you say, we have been grappling with, I would say, sometimes struggling with. I think integration means many different things, and we have tried really hard to make sure that we do not have vertical programs. That means that we don't just focus on one thing and we program for that. It's also about how we talk about parts of the SRHR together. But I would really like to advocate for changing a little bit of an approach when we talk about integration here. To be able to measure and to be able to really program, I think it's important that we take it from the perspective of those who are the beneficiaries in need of information, in need of care, and in need of the services of the health system. That means also not just the health system, I think the education system and the community entities that people are part of. So if we look at it from a life course approach, an approach of continuity of care, because that is what people want. They want to be able to talk about their needs and the services and care they need, not to different people. They don't want to go to different people. So that's one part of integration. We need to be able to have a health workforce that can really work from the full scope of the SRHR needs of people. This will be more cost effective, we know that, but really the core of it is that we want people to feel that this is for them. They are at the center. This is their life, and it doesn't come in bits. We have to make sure that menstrual health, as other parts, are as central to health as, you know, having a teacher, a desk, a book in school. You don't go to one place to read your books, and you don't go to one place to listen to your teacher, but you get it together. So if we look at it from a life course approach of continuity of care, we can then organize the health system from principles of equity in access, quality of care, and accountability. So I would like to take the example of the midwifery continuity of care. It is about accompanying and guiding the person through their life and their needs rather than guiding them through the health system. It's about having the appropriate health personnel and referral paths in place to be able to not provide too much too soon and too little too late. And that is also true for menstrual health and well-being. So just to say finally, as a health provider, because I'm also a midwife, when I meet a person, I look at that person as a whole being and knowing what may, even if they seek my care for one thing, I need to keep my attention to the other parts so that we can really have a holistic health and well-being perspective of that person. I'll stop there. Thank you.
Thank you. Thank you for that. So Dr. Askew, to elaborate on Dr. Natson's response just given just right now, in particular on how menstrual health can be integrated across the life course and into existing clinical care and health systems.
The opportunity to add a little more to Annika's presentation, but first, I really strongly endorse and support all the points that she made. I think it's absolutely critical to keep this focus on being able to develop integrated approaches, but then ask yourself, well, why are we doing this? And as Annika very clearly states, it's to be able to respond to the varying needs of individuals, and that everyone can have the information and the services and the facilities needed to ensure that their menstrual health is as good as could possibly be. And just to reiterate again, this means integration across the life course. So health systems and others involved in this need to be aware of and planning even from before menarche and to beyond menopause and afterwards. And obviously the emphasis will be different at each stage, but it means really thinking through and making sure that those responsible for providing information and services are ready and able to do so appropriately at the appropriate stages of a person's life course. I think it'll also, and this is where the issue around integration becomes important, it'll be very essential to make sure that opportunities are identified and used to expand existing service delivery interactions with persons who are experiencing menstrual cycles, to make sure that at every opportunity they're given the correct information, that where appropriate they're screened for symptoms or disorders of cycle-related diseases, they're provided counselling on the management of menstruation and of the diseases and disorders associated with menstrual cycles, and that referrals are made when necessary. So menstrual health really has to be integrated fully within health systems, like every other health issue. And unfortunately, this has not been the case previously. And as this symposium is making the case, the time really is now. There's a lot of focus on trying to ensure that national universal health coverage programs and policies are integrated, are comprehensive, and provide the full range of services and information across all elements. And this is one of those key priority elements. It has to be seen by countries as an essential element. It can't be seen as optional or not even important. It really has to be up there with all the other essential aspects of sexual and reproductive health. Now, the definition that I commented on earlier in the policy brief that we're going to see the launch of soon, these provide excellent evidence-based guidance around the types of actions that can be taken to integrate menstrual health-related information and services into a variety of existing sexual and reproductive health services. And certainly within WHO, we can move more explicitly towards incorporating menstrual health considerations as we review and update our clinical care guidelines, for example, with family planning, for maternal health, for abortion care, for gender-based violence, for STIs, HIV, etc. And also within WHO, we can mobilize our health workforce colleagues to really ensure that the health workforce is fully oriented and have the skills to provide the care that's needed and to do this effectively and sensitively. Finally, I really want to bring out the point that although both Annika and myself, we work primarily with the health sector, we don't work only with the health sector. And for this to be a fully integrated approach, we really need to look beyond the role of the health sector alone. We have to look at ways of engaging health sector with the education sector, water and sanitation, labor and employment, social development, and many other sectors. And so it will really depend at the national level to make sure that there are joined up and well-coordinated activities between sectors. And this should not only be within government. Critically important, much of the leadership in this area over the last couple of decades has been by civil society groups, advocates, NGOs, and these really need to be fully integrated with and part of the leadership of these approaches, but also bringing in parliamentarians, bringing community and religious leaders, researchers, and also commercial companies that produce the products. All of these partners will be important for a comprehensive and integrated approach to be successful. So thank you. Back to you.
Thank you, Ian. You've made very good points there around integrating sectors as well. You know, this is a multidisciplinary issue and not just an issue of health. So, Njoki, you're back. Can we quickly hear from you on how or what is your opinion in terms of the role of civil society when it comes to integrating menstrual health into SRHR? And how can civil society draw on these guidelines to advance menstrual health? Yeah.
First of all, I want to say very many apologies for all of the gaps that there've been with my connection to this call. It's really, really lovely to listen to both the doctors who've been speaking, and it's really my honor to be here alongside them. I did want to mention before a couple of things. One, I think this redefinition, as it were, is really going to be important as regards being able to differentiate between what one would call a physiological or a quote unquote normal menstrual cycle, as well as diseases whose primary mode of being manifested by the body include the menstrual cycle. And this, of course, includes diseases that cause menstrual pain, severe bleeding, etc., which have been kind of put all in the box as menses and as things that nobody wants to deal with, at least societally. I think, and kind of segueing into your second question as regards civil society engagement, it's going to be crucial that civil society engages directly with understanding and mapping out destructive social norms and engaging with ways to change these norms. One of the most important norms that's going to need to be changed is this idea that women and people who menstruate, to echo that the doctor who mentioned that, of course, it's not just women who menstruate, trans and non-binary people menstruate as well, but this idea that people and women women and people who menstruate are deserving of the pain that their body goes through at that point in time, are deserving of difficult symptoms, and are deserving of the illness and discomfort and other bad symptoms that come to them during this time. All of this is tied, of course, when you look at sexual and reproductive health, with a general fear of girls and young people when they arrive at puberty and start becoming sexually aware, sexually curious, and even start wanting to become sexually active. Of course, sometimes sexual activity at this age is not consensual and is not autonomous. It is forced upon them in many ways, and that the lack of comprehensive sexual education, as was mentioned before, is of course part of this kind of vicious cycle. So in refusing to give menstrual education in the ways that we should to both boys and girls, and in more gender expansive and gender inclusive ways, we are kind of doing a pipeline to poor outcomes, even as regards lack of comprehensive sexual education. So in general, tying together all of the difficult norms with regard to both these areas, both the medical side of things and the management of them, as well as the social norms as regards gender expectations and gender practices, is really going to be important. I think another thing is as regards the perception of pain and who deserves pain, which is of course a racialized and gendered entity. People are very comfortable, and this has even been published in medical textbooks. And I remember seeing some of these textbooks when I was in medical school, as regards the apparent belief that Black people feel less pain than other people and so can weather larger amounts of pain, which is particularly wrong. And then the lack of dignity that's afforded to people who are living in poverty, and then the infantilization, of course, that follows when you start speaking with regard to people who are living with disability. And so nobody then expands the definition of menstrual access and comprehensive sex education access to all of these people, because there's many imaginations about who they are, what they deserve, and what types of lives they need to live. This is all going to be really crucial. And I guess maybe my last point as regards civil society engagement has to refer to spiritual spaces and religious spaces, which have been in the past profoundly invested in patriarchal understandings and moving in the world. And so you find that they contribute greatly to the lack of education and the lack of spread of appropriate and culturally relevant menstrual health engagement. They also contribute to the lobby that goes against comprehensive sex education. And so without engaging in these particular arenas, it will become very, very difficult for this message to go out into the public in the ways that it should. I do think maybe, and this is the actual last thing that I'll say, that we have to ask harder questions as regards medical research. The whole world, because of this COVID period, has become much more acquainted with medical research and the outcomes of medical research and the processes of medical research. And one of the biggest questions that I'm seeing currently is with regard to the effects of the COVID-19 vaccine on the menstrual cycle. And when we cycle back then to a lot of other medical research modalities, you find that very little attention is paid to the effects of medicines, the effects of vaccines, the effects of all these chemicals that we're having to put into our bodies on the menstrual cycle and what they mean for people who menstruate, who time and time again are left out of cogent understanding within medical research. And so this expansion is really, really going to be promising, but what is left to see is how well we're able to implement and which paths we're going to take in order to implement it properly.
Thank you, Joku. Thank you very much. Very passionate presentation there. You've really hit the nail on the head, really, in terms of medical research, and how COVID vaccines are impacting or will continue to impact menstrual health. We do need to move on. I would like to thank our panelists, but if we have a bit of time at the end, we will come back to you, panelists. I want to give this opportunity now to Dr. Julita Onabanjo, who is the Regional Director for UNFPA East and Southern Africa, to launch the guidelines which we are about this afternoon. So please, Dr. Julita, I invite you to make your remarks and launch the guidelines. Thank you.
And thank you, Dudu. Really excellent panel already. Distinguished delegates, colleagues and friends, good afternoon. Let me start by acknowledging and thanking each one of our esteemed panelists on this first part of today's plenary. And before I officially launch the sought-after technical brief on the integration of menstrual health into sexual and reproductive health and rights, allow me to make 3 very quick points. These points have been expressed in many different ways since we started this fabulous symposium yesterday. And indeed, they pick up on the valuable perspectives that have been shared by Dr. Njoki, Dr. Ian Askew, and of course, my sister, Dr. Neka. My first point is really on the definition of menstrual health. I think we are all delighted to see that since the last symposium, global menstrual health practitioners have got their heads together and under the Menstrual Health Collective have adopted a comprehensive definition of menstrual health. And with this definition, UNFPA, the United Nations Sexual and Reproductive Health Agency, not only views menstrual health as a significant contributor to the other 9 comprehensive sexual and reproductive health and rights outcomes, and Neka referred to them as elements, but also a critical sexual and reproductive health outcome by itself. And so menstrual health is an integral part of sexual and reproductive health and rights. And access to good menstrual health is a matter of human rights and essential to good public health. Menstrual health is therefore a core element of UNFPA's mission, and our mission is achieving a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. I think the second point I want to make, and I would like to underscore, is this importance of identifying and scaling up multi-sectoral and integrated approaches for attaining menstrual health and sexual and reproductive health outcomes. I think progress towards achievement of universal access to menstrual health and sexual and reproductive health, information and services, requires us to think big, to think scale, but also to think urgency. And this could be achieved by optimizing the synergies in advocacy that we do, in policy formulation and implementation, in financing, in service delivery, and in evidence generation. Improving the horizontal integration, and I think Aneka spoke to some of this, such as with the different sectors, and Ian said the same, and we looked at health, education, community, social affairs, gender, water and sanitation, environment, labor and justice, is equally important, as is the need for improving, and I'll borrow again Aneka's word, vertical integration around policy, planning, budget and financing, capacity development, delivery and performance measurements within the health sector, and including community and primary health care levels, and this whole notion of strengthening health systems in general. This 2-part technical brief, developed for policymakers, program managers, and practitioners, provides a framework and guidance on how to strengthen the operationalization of integration of menstrual health within sexual and reproductive health policies and programs across the sector and within the sectors, and particularly the health sector. The brief uses a people-centered life course approach to consider menstrual health and SRHR needs of girls, women, and all people who menstruate. And I thank Dr. Njoku for really stressing that point again. And from premenarche to postmenopause, in development as well as humanitarian settings, and really leaving no one behind. So dear participants and partners, I think already we've heard that there's so much progress that has been made on the continent, and especially in East and Southern Africa. And Dudu, thank you to SADC Secretariat as well, because with you, we've really partnered on integration, but on many other things, and I'm really excited. in the progress that is being made to integrate the response to menstrual health, including the introduction of menstrual health policies, and we've heard from really excellent country examples of really comprehensive efforts around that. Yet despite this, and I said it yesterday, I say it again today, many girls and women of reproductive age in Africa, and those who still menstruate on any given day, still lack access to the necessary education, information, products and services to experience that healthy menstruation and to manage all the forms of uterine bleeding in dignified, empowering, safe and healthy manners throughout their life course. And that deprivation of menstrual health is especially true for persons who are also experiencing other intersecting layers of discrimination and inequality. And again, those who live in settings that remain vulnerable and fragile. So now we have many emerging opportunities, not only the partnerships and the networks that we will have through this symposium. We know the Africa Union, and I'm sorry they were not here to join us in this panel, but Dudu's there representing the regional economic communities as well. But we have Karma Plus, and we do think that this technical brief highlights important country efforts and evidence and recommendations to address effective integration and mainstreaming. And we also recognize that translating the comprehensive definition of menstrual health into practice through multisectoral and integrated approaches will require, and this is my last point, additional financing. And we know that integration of core functions of multiple delivery systems will provide and produce efficiency gains. But efficiency savings will not be enough to support our goals of achieving universal access to sexual and reproductive health and menstrual health. And therefore, we really need to redouble our efforts to increase external as well as domestic financing by developing costing models, investment cases, and using innovative financing instruments. And so I look forward to tomorrow's plenary, where we will be able to hear more about menstrual health financing options. But for here, I would like to really reiterate the fact that by situating menstrual health and SRHR within country-specific universal health coverage policies, financing, delivery, and financial protection arrangements should improve sustainable financing for menstrual health and SRHR as a package. Colleagues and friends, we're going to say it again, the time to act is now. And with this technical brief, we can improve the integration of menstrual health and sexual and reproductive health, and we must. With the 2030 deadline for the Sustainable Development Goals and the ICPD Programme of Action and the ICPD 25 Nairobi Summit commitments, as our North Star, we must double down on our actions to expand our efforts to respect and protect the fulfillment of rights of all people who menstruate. It is therefore our collective responsibility to embrace and operationalize this technical brief that I'm going to launch in a few minutes with urgency. Let me end with a word of sincere appreciation to thank our dedicated teams from the Africa Coalition for Menstrual Health Management and the UNFPA Eastern Southern Africa Regional Team. I'm very proud to be supporting them and leading them. And I really do want to spend just a few minutes just to specifically name some very important people. Puleng Letsi, who now works with UNAIDS, but it was the past coordinator on our side as UNFPA for the Coalition Secretariat. Renata, who you met yesterday, is our regional advisor and coordinator for the Safeguard Young People's Program and youth leader, but she's done fabulous in bringing us to where we are today. Maria is our UNFPA CSC specialist and disability focal point. I thank her. Maren, who took over from Puleng, is also in the back scene doing a lot of work, but was very vital to the brief. Maya, who also has left the team, but has joined our UNFPA Tanzania country office, and she was very much part of the last symposium. Richard, who you're going to hear from in a few minutes, together for SRH technical coordinator, and Jyoti, the integrated SRHR team leader, and currently our Deputy Regional Director acting. I also want to thank the UNFPA Technical Division in New York, Danielle Engel, our technical specialist on adolescent and youth, and Aneka, who you met just now, our chief of the SRH branch. And all experts in menstrual health from civil society, the academia, the regional economic communities, who all contributed to this technical brief. And allow me to end by thanking the Swiss Agency for Development Cooperation for making this work possible through the Safeguard Young People's Program. With these remarks, it gives me great pleasure to officially launch this technical brief. And here it is, and you'll be able to find it on the website very soon. With that, I say thank you and hand you back over to Dudu.
Thank you very much, Dr. Julita, for your very inspiring statement. And we look forward to receiving these guidelines in the member states. And I speak for SADC here. And this will also be an additional resource to the resources related to SRHR that we have here in the as SADC. I'd like to take this opportunity to thank the panelists. We are out of time, so I need to conclude this. Thank you, panelists, for your very insightful perspectives that you've shared on the topic of integrating menstrual health into SRHR. Very key messages, important messages that have come out from your experiences and from the work that you've shared. A lot on rights was shared, changing norms and perspectives, and I think that's the direction we want to go. Leaving nobody behind, and engagement, civil society, governments, partners who support the work, and everybody who has a say and who has a stake in this issue of menstrual health. So with that, I'd like to thank the audience as well for being a very good audience. Unfortunately, we couldn't take all your questions, but as the speakers were making their presentations, I believe some of the questions were answered. Thank you very much for that and for interacting in the chat box. So I would like also on my own behalf and also on behalf of the SADC Secretariat, thank the organizers, UNFPA and the partners for inviting us to this panel and for moderating it. We really appreciate it. So everybody, thank you, and we will take the next stretch. There will be the next session of this afternoon, and I'd like to hand this back to the team. Thank you very much and have a good afternoon. Thank you.
Thank you so much for joining us for the last hour. We're going to have a 5-minute break and we'll come back for another hour with some presenters. And we look forward to seeing you in 5 minutes.
older. If we teach children at a very young age, right? So when you teach a child when she's still growing, she's gonna know that this thing exists, and then we have to feel comfortable about it because it's normal. So if we teach a child at a very young age, they're gonna pass it to their friends. Children do talk. So if we get a time, we should just give them awareness of what's happening and make them feel that this thing is just normal. There's nothing they can do about it.
I started at almost the age of 16. I was at school, so it was kind of weird, but I was expecting it because I had been having period cramps, I think from the age of 13, so my doctor told me I should start expecting my period. I did have access to information. In primary school, we were taught, I think in grade 5, about menstruations, and I think my mom also played a role in that. I was at the salon one time, and this lady was talking about how her 8-year-old is having a period. So I think, we need to start having these conversations with kids because it's happening.
During my periods, I feel like, I don't want to go out, just want to sleep all day. I started menstruating when I was 14, my first year of high school, I think. How did you feel? It wasn't normal, but then you get used to it. So when I started my periods, and then I asked my mother and my aunt about it, and my aunt was like, if you just stand like next to a boy, you'll end up falling pregnant because it's the period. You're a mature woman now, you're young. So they told me if I stay next to a boy, then I'll fall pregnant because I have my period. So then for that time when I have my periods, I won't go to any boy because I know if I stay next to you, I'll immediately fall pregnant. So that's the story they told me.
Hi, welcome back. Some of you may be joining us new, and others may have been with us just a few minutes ago before we took a break. Either way, we're really excited you're here to join us for this session, Integrating Menstrual Health into Sexual Reproductive Health Policies and Programs. And this section is going to focus on lessons learned from research and practice. We just had a really exciting session where Dr. Julietta kicked off the technical brief of integrating menstrual health into SRHR. So we're really excited for the discussion that we're going to have today. Just by way of introduction, my name is Diana Nelson, and I will be the facilitator for this session, and I'm the Global Advocacy Director for Days for Girls. I'm so excited about this topic because I see in my work the need to have this integrated. As I just mentioned in the previous hour, we had a panel discussion as well as Dr. Julietta's talk about to introduce these technical brief guidelines and what that means to integrate menstrual health into the sexual reproductive policies and programs. The technical brief really is an exciting opportunity for us to expand the access to menstrual health through using various SRHR platforms across the life course of a woman, as well as at the same time expand the SRHR by integrating it into menstrual health programming. So the purpose of this session is to build on the information that was shared in the last hour. And we're going to do this by exploring and gaining insights into the opportunities and challenges that integrating menstrual health and SRH might present. We'll draw on research and program implementation, looking at evidence and lessons learned from programs integrating the menstrual health and the sexual reproductive health. How this will be structured, we're going to have 3 presentations that will be between 10 to 15 minutes. And I will introduce the speaker briefly, and then before each of their presentations, share more about them. Everyone will be muted, so please put your questions in the chat box or in the question and answer, and please feel free to make comments during the presentations. The 3 speakers that we have today will be Mandikudza Tempo from Zimbabwe, Maria Baptiste from Cote d'Ivoire, and Alethea from Osborne, who is from the UK but's worked in East Africa and the Middle East. So I'm going to introduce our first speaker, which is Mandy Tembo, who goes by Mandy. And she's a PhD research fellow at the London School for Hygiene and Tropical Medicine. Her research focuses on menstrual health and adolescent sexual health in Zimbabwe. Her presentation is on the integration of menstrual health into SRHR and lessons from research with adolescent girls and women in Zimbabwe. So Mandy, I'll turn the time over to you.
Hi everyone, thank you so much for taking the time to be here. Like Diana said, my name is Mandy Tembo. I am a PhD research fellow based in Zimbabwe and doing research on menstrual health amongst young women in Zimbabwe with the London School of Hygiene and Tropical Medicine. If we could get my presentation up, we can get started. Next slide, please. So just to give some context, I'm going to give a context of how menstrual health is in Zimbabwe. We made last year on Menstrual Hygiene Day that will give context to the work that we've been doing in Zimbabwe. I'll then go into detail on the intervention and then share our challenges and then lastly, the lessons we've learned in the field and the work that we're doing. Next slide, please. So in Zimbabwe, we are very much, menstrual health is a priority, but it's something that has only recently come about. So if we think of the journey of menstrual health as a marathon, we are very much at the beginning of that journey. We don't have any policies that are menstrual health specific, but we have those that are menstrual health related. So for example, within our Education Act, we have something that's provisions for wash in schools that talks about separate bathrooms for girls versus boys. And then the National Family Planning Council wants to address MHM in schools and in youth centers, but much like other parts of the world, it's not very well monitored and also we're not able to see how well it's being implemented. Another thing is that we found that there's very limited access to menstrual health and products, menstrual health information, products, and pain medication. And then taboos and myths around menstrual health and around restrictions around those who menstruate are very much still a huge role and informer within our communities. And then there's very little peer-reviewed literature about menstrual health in Zimbabwe. I think there's a lot of anecdotal information, but not a lot of research. And that's really where we come in. So the next slide is going to talk about the work that we do, and then I'll talk about what we've learned from that research. Next slide, please.
Happy Menstrual Hygiene Day and welcome to Chiedza. Chiedza is a community-based intervention providing integrated HIV and sexual and reproductive health services for young people aged 16 to 24 across Zimbabwe. In honor of Menstrual Hygiene Day, we wanted to highlight some of our work. As part of Chiedza, we are providing a comprehensive menstrual health and hygiene intervention that gives young women access to menstrual health education, pain medication, and a choice between the menstrual cup and reusable pads. As Chiedza, we believed in informed choice, providing young women with adequate support and accurate MH information, and allowing them to make a choice in regard to their menstrual health management.
So that was just a brief overview of what we do here in Zimbabwe. So the Chiedza trial is a community-based intervention looking to improve HIV outcomes amongst youth. What we do is provide a comprehensive set of SRH services for free to young people aged 16 to 24 in clusters across the country. What we want to see is if in the places that we are versus the places that we aren't, are there improved HIV outcomes over time? We are in 3 provinces in Zimbabwe: Harare, Mashonaland East, and Bulawayo, and we have been implementing for 2 years or more. We've extended the implementation because of the interruption by COVID. So when I talk about an integrated SRH service, we provide STI testing and treatment, HIV testing and treatment, family planning methods, condoms, menstrual health education, and a selection of menstrual health services, including reusable pads and the menstrual cup. Next slide. So the reason we decided to include menstrual health in our comprehensive sexual health service is that when we asked young women what they wanted, an overwhelming amount of them said that they needed assistance in terms of menstrual health. A lot of them had poor or inadequate menstrual health in that they didn't feel good about their periods, didn't feel confident when they had their period, and they couldn't access their period products. Another thing that came up that maybe doesn't come up as often, but is starting to be talked about a lot more, is the idea of pain and how pain affects your everyday activities. So a lot of people talked about not having access to pain management medication, but also not having an understanding of other ways they can manage pain. So as Chiedza, we wanted to include the menstrual health component in our study so that we would really cater to the needs of young women. Next slide. So in greater depth, in terms of what the menstrual health component looks like specifically, we provide reusable products. So we have the reusable pads and the menstrual cup. And people have a choice to choose either one of the two. We do encourage young women to try a product for at least 3 months. From the literature, we found that it takes at least that amount of time to get used to a product that you've never used before. If after 3 months you still don't like the product that you've chosen, you are welcome to come back and change your product. And so we also provide underwear so that they're able to, if they're going to use their reusable pads, they have underwear that they can clip the reusable pads to. We have education in the form of our youth workers. So these are the implementers of our program who do a comprehensive session on menstrual health in general and then talk more about the products and how to use them and how to take care of them. We also provide medication. So we have paracetamol or ibuprofen. They can choose which one they would like. And every time a young person comes to Chiedza, we're able to see, do they take up menstrual health in terms of a product, in terms of pain medication, or in terms of just information and support over time. So what we wanted to find out in this study is the acceptability of the intervention as a whole, and then look at the uptake and effectiveness of the intervention within Chiedza. So really looking at, does the integration of menstrual health within a community-based sexual reproductive health program work? Is it acceptable? Is it needed? What is the uptake? And what informs the acceptability of that intervention? And to assess that, we had both qualitative and quantitative methods. So quantitatively, we are using a biometric system called Symprints. And Symprints basically uses a fingerprint for each participant that comes in and logs in every service they take up when they come to our center. So we get real-time data on who is coming, how often are they coming, and when they come, what services are they taking up. We then follow that up with qualitative data through focus group discussions, in-depth interviews, and observations, where we look at what the quantitative data is telling us and investigate more on what is informing the uptake, what's informing product choice, and so on. Next slide, please. So what are our findings so far? Quantitatively, we found that the intervention has been very, very popular. So we've served approximately 22,000 young women over time, and 97% of those people have taken up an MH, so a menstrual health service. So this is coming to our center, asking for information about menstrual health, or taking up a menstrual health product. When we disaggregated that by age group, so we are serving 16 to 24, from people aged 16 to 19, which is our younger girls, 96.8 of those people took up a menstrual health product. When we look at 20 to 24, we have 97.7. So basically, almost every young woman that's coming to our center is engaging with the menstrual health intervention. And of all the services we offer at Chiedza, as I sort of expanded on earlier, menstrual health is overwhelmingly the most popular. Next slide. So we wanted to understand what is informing the high of the menstrual health intervention. And we already kind of knew this from the formative work that we did. But again, we heard that there's a huge need for menstrual health assistance within our communities. there's a lack of access to products and a choice of products. So we're introducing young women to products that maybe they weren't too familiar with, which is the cup and the pads, and having information about how those products work and having access to those products for free was something that was very much well received in our communities. Another is having access to pain medication. And then the last is having access to these services within a youth-friendly environment. So Chiedza has tried to be youth-friendly as much as possible. So that means having providers that talk to you, have conversations around menstrual health and reproductive health, having games available at the center, music, books they can read. So it doesn't feel like you're coming to a clinic, but really like a community center where you can engage with other young people, but also get health services. One other thing that we notice is that context is extremely important. The social cultural aspect really played into the products that young women chose. So we are in Zimbabwe, which is very much a conservative community. And we found that even though we would talk about both all our products equally and talk about the pros and cons and how to take care of them, we found that young women were a lot more prone to choosing reusable pads as opposed to the cup, just around the taboo of inserting something into the body. And while they were empowered when they were at the Chiedza Center to try something new, like a menstrual cup, we had to consider that they're going back into a community where they're going to engage with their parent, their partner, their caregiver, who already has their own ideas or myths or misconceptions around different types of menstrual products. Another thing is environmental factors. So thinking around access to water, access to a place to change your product really did inform what product choices young women made. The last thing is that there was a lot of evidence that the integration of the intervention into Chiedza as a whole facilitated engagement in the SRH service. So one of our quotes was, "I personally came here with the intention to get pads. And when I entered into the Chiedza booth," so that's the service where they have a one-on-one encounter with a provider, "I saw a very friendly service provider and felt free and comfortable to talk." So you're able to talk about other services that we offer, including family planning, STIs, and HIV testing, having had that sort of opportunity to just talk about menstrual health and then engaging in something else. Next slide. So some other findings, our participants thought of Chiedza as a place that gives out pads. So again, it brings back the idea of context and thinking about sort of the risks and benefits of integrating menstrual health within SRH. Within Zimbabwe, with the huge unmet need, menstrual health became the most popular service, so much so that what is a comprehensive sexual and reproductive health service became known as a pad service because it was overwhelmingly popular for giving out menstrual products. The other thing is that a lot of male participants felt like they were being neglected because they felt that the service was now just for females. And to have an understanding of that and the context, I think, is incredibly important when you're trying to implement this in a community or in an environment. It's incredibly important to make sure that you are catering to both young men and women, especially as we know that when it comes to health services, it's very hard to engage with young men. Another sort of a finding from our providers was that while the menstrual health initiative brought a lot of young women into our centers, it also meant added amount of work. And this is in two parts. One, a lot of people are coming and the service providers don't necessarily have as much time to engage with everybody because there's so many young women coming. But the second part is to really engage and make sure that your menstrual health intervention is effective. There is a need for comprehensive education, and that needs to happen over time. So that introduction to menstrual health, that introduction to the different products takes quite a bit of time. And even after that, participants would come back and ask more questions. And outside of service hours, participants would message or WhatsApp and ask follow-up questions. So just to think around what are ways that you can support the implementation and sustainability of menstrual health interventions beyond just the work service times. You do need to sort of have a system in place for constant support and feedback. Next slide. So some of our strengths, limitations, and challenges. So our strengths were that we did include a pain management aspect. So having access to pain medication and then education on other forms of pain management like exercise or using heat. Our intervention was multi-component, so it was not just giving out products, it was accompanied with education and support, and also that it was part of a much more comprehensive sexual reproductive health package that included family planning, STIs, HIV testing, and treatment. The inclusion of boys in our menstrual health education. So to sort of address the amount of time needed to really get in depth with menstrual health as a subject, we had group discussions, and for those we included both young men and women together, and we found those to be incredibly engaging and incredibly informative. And as you can see in the picture, we actually have one of our male implementers doing the session. And he was amazing. And I think it made the young women feel a lot more comfortable and reiterated this idea that it should be normal and not something to be ashamed of to talk about periods, not just with other menstruators, but with males as well. And then we were looking to address the menstrual health needs of not only girls that are going to school, but girls out of school. Our limitations, so some logistic limitations in terms of delivery times of the intervention, and this goes into the challenges as well. We obviously were operating through COVID. We were able to get clearance as an essential service because we were providing reproductive health needs to young people. But in sort of coming out of the initial lockdown in Zimbabwe, we did have some interruptions in service delivery. And when we did deliver during the COVID times, we had to adhere to COVID protocols. So service times were limited because people needed to get home in time for curfew. Also, there was social distancing, so the service was slowed. We also had to take out our youth-friendly elements of having games and pool and music because we needed to make sure that people would get a service and then go back home and not gather in crowds. So I think as a team, we definitely feel that changed the dynamic of our service because it was such a big component, the youth friendliness, and that definitely was limited because of COVID adherence. Next slide. So at the end of this, our lessons learned is that partnering is maybe a challenge, and you really need to take consideration of the context in which you're working in. Menstrual health is definitely a gateway to talk about sensitive topics, especially in conservative communities. The inclusion of menstrual health in SRH can increase female engagement and participation, but if it's just a service that caters to both young men and women, it's incredibly important to take the male perspective into account because sometimes the menstrual health component can overshadow other SRH services. And then the last is that community engagement is key. It's well and good to interact with the individual, but that individual is going back into the community. So for sustainability and acceptability, we do need to engage the community as well. Thank you.
Thank you, Mandy, for that really informative research that you shared with us. There were so many great things. I was taking notes the whole time. But one of them that I really felt tied back into the previous session was the way that you're integrating it, looking at from the beneficiaries' need, and taking into consideration that they're going back into the community, allowing them to have the right to choose what product. So I think that's a really key element as we look at integrating menstrual health and SHR more, that we look at it from the beneficiary view. So thank you so much, and bringing in that importance of the community engagement. So we're going to move on to our next speaker, which is Marie Baptiste, and she is the country representative for Population Services International, or PSI, in Cote d'Ivoire. And she has grown the country operations there, launched the reproductive health portfolio for PSI there, and oversee the implementation of SR SRH, HIV, malaria, and sanitation programs. We're excited to have her with us, and she'll be discussing the benefits and risks of integrating menstrual health into SHR and the lessons learned from West Africa. So Marie, thank you for your presentation.
Good afternoon, everybody. Happy to be here. Before we start, I will say that we are experiencing some power cuts in Abidjan from time to time. So crossing our fingers that won't happen. But if it does, it will be in 2 minutes. I'll be back on with the generator. So as said, I will be speaking to you about the benefits and risk of integrating menstrual health into SRHR, and I'll be sharing some of our lessons learned from implementation in Cote d'Ivoire. So we can start with the presentation. First, we'll start with the first slide here, which is really we'll talk about how globally here at PSI, how do we look at menstrual health and hygiene? And what we really this represents how we look at menstrual health and hygiene at PSI, because we believe that to meet all needs, we will need to have a comprehensive and cross-sectional approach with the beneficiary or the user at the center. And this is what we call the user-powered menstrual health and hygiene. So the components of this are menstrual health and hygiene integration into SRHR services, awareness raising about menstrual health, to empower informed bodily choices, self-care, and advocacy, as in really advocacy for menstrual health and hygiene as a cross-cutting issue. I'll be speaking particularly around the first three: the integration of SRHR services, self-care, and awareness raising with an example from Cote d'Ivoire. As we wait for the next slide, I will say that in 2018, PSI, we did an inventory across our 50 networks to really understand if countries were already implementing menstrual health and hygiene activities or if they see a need to do so. And really the responses were overwhelming, and countries were specifically looking at more information, more guidance on how to integrate menstrual health into SRHR services. We also collected insights in terms of collecting information from our beneficiaries and our users, and we asked them about linking menstrual health and SRHR services. And these bullet points here are really some of the responses that we received, right? We know that some women see menstrual health, their menstruation, as normal and natural, and as well as confirmation that they are not pregnant. Some women want to use contraceptive as a way to reduce the bleeding they experience on a monthly basis. Girls and women use social media to ask questions, particularly Facebook pages, to ask questions about menstruation and bleeding concerns. Third, girls and women are afraid that contraception will change, whether it's increasing or decreasing the bleeding they experience on a monthly basis. And the important part here is that we know there's a close association between bleeding and fertility, the linkage to motherhood, because we know that girls specifically tell us that mother is their life goal. And certainly anything that changes their experience in their bleeding means that that causes them to worry more about their fertility, and that means that it threatens a very important part of their life, a very important life goal. So we know that this is a very delicate issue that needs to be addressed properly. Fourth, we know that menstruation is certainly associated with sexual debut or perhaps readiness for marriage in some places. And questions about menstrual product access and preferences are often answered in combination with follow-on questions about sexual health. Next slide, please. As we transition to the next slide, we want that adolescents and youth, they want to be supported through their entire journey with correct information about menstrual health management. As we talk about, of course, from the client side, then it's also important to talk about the professionals side. We know that I was asked to speak specifically about the benefits and the risk of menstrual health and hygiene, sexual reproductive health integration. We see many benefits. Now we see this is a benefit because as an opportunity for women and girls to be given information about their bodies and menstruation and fertility. We get an opportunity to for women on contraceptive-induced menstrual changes, right, including bleeding changes, because we know that women who use contraception are often experienced to their menstrual bleeding, and they fear that anything that these kinds of fears, if they are not answered to properly, they may cause many women to abandon, to discontinue contraception or just not adopt altogether. This is also an opportunity for providers to provide information about SRHR-related bleeding in SRHR services such as miscarriage, abortion, as well as create a safe space of support for girls who don't necessarily see themselves as sexually active, but certainly may soon be. And it's also an opportunity to explore mental health for diagnosis of HIV and cervical cancer. Next slide, please. We have here projected the results from PSI Zimbabwe that train mobilizers to talk about menstrual health, and that also developed a menstrual health manual to guide the discussion and introduced a menstrual. By using menstrual health as an entry point for adolescents, the conversation about SRHR and safe sex was much and safer and considered more relevant to adolescent girls because many of them initially did just want to talk about their bodies and their changes and the change experience during menstruation, and eventually they talk about other services. So that this is what here in the graph is definitely the changes in terms of the number of people we were able to reach to change the approach. Next slide, please. Okay, I think there's something here not appearing in the slide, but basically in terms of, although there are many benefits, although there are many benefits to integrating menstrual health into SRHR, there are some potential risks because we know that not all providers have sufficient training or tools to identify and address menstruation related issues. So FHI with FHI 360 and PSI work together to develop tools for healthcare workers to use as an aid to address client questions and about changes in bleeding. Women understand the changes they experience, particularly around common changes when you use contraception, and to assure them that they are not harmful. As we are looking at here in terms of this tool, normal, in terms of to make sure that they know that it is normal and safe to have changes to your monthly periods when you use a family planning method. And we use this as to really point out the opportunities that you have when there are some changes, because some women experience much lighter or lack of bleeding, and that's an opportunity for them to give them greater freedom in their daily activities, that we reassure them that their monthly periods and fertility will return once they do stop using family planning method of their choice, that the different family planning methods can cause different bleeding changes, and that it is important to talk to the doctor or the midwives, depending on their countries, to make sure that they choose the right choices for them, and that the absence of monthly bleeding by itself is not an indication or confirmation that they are, and that it is really important that everyone really speak to their doctor about any changes that they have in their monthly bleeding that actually limit their daily lives. So because their provider may be able to give them something that can help them manage better. Next slide. Leveraging self-care interventions to address menstruators' needs and enable them to become active agents in their health. Right? So access to quality information and tools around menstrual health can really improve everyone who menstruates, will improve their awareness of their bodies, improve their ability to prevent illness and maximize their health. Girls and women who can better track their menstrual cycle as part of their daily practice, and they will recognize menstrual patterns and symptoms as well, and that can help them really manage themselves better, and eventually may help to reduce the burden on the health system and support a more into the health system when needed. I'm sorry, it seems like the projection here, I guess the words are not as clear, but certainly I'm sure we'll have, I can answer or clarify anything else later. Next slide. What we have here is a projection of our Facebook page, actually, from Côte d'Ivoire. We use social media as a way to reach young women and girls about it with information on SRHR. And here, this is the Facebook page, and it's called Entre Nous. And here, I'll be focused on an example. So we'll talk more about what we found through that experience. We studied through a 3-month period, we studied the volume of messages that we received through our Facebook page. And what we see is that we received about 1,100 messages that we received from November 2018 to January 2019. From the over 1,100 messages that we received, 40% of them were related to the menstrual cycle. So really, this is a clear indication and confirmation of how much thirst there is for this kind of information and guidance. Next slide, please. What we have here also is also from the page. We have every Wednesday on a weekly basis, based on volume and what we saw, we changed to include a program, whereas once weekly, everyone is guaranteed to speak to an actual midwife. So we have Sage-Femme Gabi. And because we know it is important that questions about menstrual health are channeled properly and are answered properly by someone with the correct knowledge around SRHR. Because we know that the potential risk here, as much as the virtual world gives us an opportunity, it also has a risk, because we know if there isn't proper channeling and answering of questions, then there won't be adequate referral. And what we have here is the projection for those who can speak.
That we have lost Marie. What a phenomenal presentation. We'll try to get her back on. I think what we'll do is we'll go ahead and move to Alethea, our next presenter. And then if we can get Marie back on, we will definitely pick her up and finish up some of the things that she said. So interesting, right? One of the things that I thought was fascinating was of all of the girls that were reaching out for self-care, 40% of them wanted to know about their menstrual health and having that accurate information is really important. So let me go ahead and we'll introduce our next speaker, Alethea Osborne. She has helped design and manage the first menstrual health funding round for the multi-donor SRHR Challenge Fund Amplify Change, and is now responsible for providing technical oversight and research analysis to over 30 grants in sub-Saharan Africa and Asia that advocate for SRHR for women and girls. She's also a technical specialist in gender and social development for Mannion Daniels. Alethea will present a mainstreaming menstrual health into SRHR, learnings from Mannion Daniels and Amplify Change. So over to you, Alethea.
Hi everyone, and thanks so much for the introduction, Diana, and it's great to be here today. And I think also just so gratifying, having listened into the session for the last nearly 2 hours, to see how much of the findings and the steps that we've taken in the last, not just 2 years since the last symposium, but really the last 5 years or so at least, since menstrual health started to become on the agenda, just how far we've got. And if we can get my slideshow up, that'd be great. And I can just do a little bit of an explanation as to where we're coming from with some of the findings that we've had so far with really trying to support grassroots organizations. So as a brief bit of context, next slide, please. My name's Alethea Osborne, and I've been working with Mannion Daniels, who is a B Corp certified development consultancy and fund management company that's based in the UK, Kenya, Nigeria, Somalia, and Bangladesh, and specializes in managing large funds that gets grants out to civil society organizations, particularly across sub-Saharan Africa and South Asia. And within that, one of the big funds that we've managed and incubated and grown to the point where actually this year they've now become a separate entity, which is fantastic, is Amplify Change. And it's a multi-donor challenge fund which provides grants to civil society groups. So what that means in practice is that we have different funding rounds which we receive applications for, and then provide the grants along with technical oversight and due diligence and organizational strengthening around areas like safeguarding. And so moving on to the next slide, one of the things that I really wanted to highlight, and I think it's brilliant that it's already been stressed, is that while this session is obviously focusing on how menstrual health should be integrated into SRHR more broadly, it's been really clear for us that menstrual health needs to be named as its own thing. And it needs to be identified as something that should not just be assumed as happening within SRHR. And so for us, when Amplify Change started, it became more and more clear from the applications that we were receiving that people were wanting to integrate work with periods within their work, but didn't really necessarily know if they could or how to do that as possible. And so we decided in 2018 to have a specialized funding round focused on menstrual health. And we were hoping to provide 30 grants, and for a really competitive round, we'd hoped that we would receive about 200 applications. As it was, we received nearly 900. And so I think, as was mirrored in the presentations that we've just seen, what was really clear is that this is something that's in huge demand. That is far higher than we've ever received for a different funding round. And so while within SRHR, we're very aware of the importance of making awareness around issues of access to self-abortion, harmful traditional practices, it's also really crucial that these day-to-day elements that are being dealt with all the time should not be overlooked, and they have to be identified. And I would say that while we name that and it's very much grown within the SRHR space, as has been stressed, one of the key takeaways, I think, for us is also learning how to work cross-sectorally. How do they intersect with gender? How do they intersect with the education space? How does it intersect with WASH? And I think even more so now, we need to think about the environmental consequences. And so just to give an indication of our commitment to this, Amplify Change has given out over €3.5 million worth of grants. And as you can see, the bulk of them, 55 of them, have been in sub-Saharan Africa. So I just want to give some really brief examples from some of those civil society organizations that we've supported to really highlight three main things across them. So one, as I've already mentioned, is that multi-sectoral approach. And it's fantastic to see how many people have really focused on that today and really stressed that we need to ensure that those learnings are working across the spaces. The second is to say that this has to be demand-led. Not a single one of the menstrual health grants that we've provided has been the same. Not a single one of the applications was the same. It can be the same topic, but context is always going to be different. What's needed is always going to be slightly different. And the other thing is really to ensure that there's a sustainability and a long-term aspect. It's fantastic, the awareness that has grown around the fact that girls in schools might need a pad to ensure that they can stay in class for that day, but that is a very short-term solution. There's also got to be an understanding of the fact that a pad has the equivalent of 5 plastic bags in it. What happens to that next? What does the girl do the next day? And as we've discussed, this life cycle approach of what happens once she leaves school, goes into the workplace, later on what happens when she hits menopause. There's so many elements there. And so we really need to think how we're equipping both people and institutions and policies to ensure that longer term approach. So if we go on to the next slide, the first example that I want to highlight is from Malawi, and is an organization who are really focusing around advocacy and human rights. And so showing, again, that intersection between rights and SRHR in this context. And the entire focus of their grant, which was a 1 year long grant, was to advocate and lobby and work with the parliament and advocacy groups to ensure that there was a budget line for the provision of menstrual products for female prisoners in Malawi. As you can imagine, they're often living in very overcrowded situations with not a lot of access to water or space for changing or for washing things. So if they're using anything at all, it's often rags, which might increase the risk of infections. But more than that, it's a matter of dignity and not having another thing that you're having to worry about in those conditions. And by ensuring that rather than just providing pads themselves, the organization worked and lobbied to ensure that there is now a named budget line to ensure that the Malawi Prison Service provides this. That's ensuring that long-term change and is really having done a consultation with the inmates to understand what's needed, what would be provided here. I just want to flag that on each of these slides, there's contacts for the organizations, and I would really encourage you to go and look up or reach out to them if you want to connect directly, and that they've all agreed to have those shared. So if we go on to the next slide, the next example comes from Angola, and is a nice example of that nexus between, as has been discussed before, SRHR, comprehensive sexuality education, and working in schools, but also going beyond thinking of just, okay, so the girls in school right now, how do we support them? But also understanding some of the bigger picture. And I think we all are aware of the fact that there needs to be product provision, there needs to be training, and there's been a huge amount of work done around curriculums. And that's been fantastic, but I think we also need to be aware of not trying to reinvent the wheel. There are now so many curriculums out there. And I think often also there needs to be a reflection on what level of complexity is there needed in those. I think one of the key learnings we can take from COVID is that people can actually change their norms very quickly. We all learn how to distance, how to wash our hands without having to be virologists understanding exactly how the virus works. And that's a similar thing here. I think we can simplify and understand what needs to be taught. But at the same time, if the person introducing the topic is not comfortable with it, then that's irrelevant, okay? So for us, what was really interesting was thinking, how do you improve that teacher training? How do you ensure that they feel ready to be able to discuss the topics, to answer questions and ensure those conversations are open and free? And so this organization was working through the Teacher Training College, where teachers come together to do formal training for a year before being sent out on placement across the country. And so by working through the Teacher Training College, they were able to have a centralized system in which many of those future teachers were then aware of it as a topic and could then go out into the field. And then they all come back after their years of placement in the field to share some of those discussions and see what could be built on. So this is something that I think is really interesting, that they've also been able to leverage on that and are now working with UNFPA and BGIL to kind of try and extend this and understand how do we work to break down those norms and build up that knowledge base that can carry on. And finally, if we go on to the next slide, the last example that I wanted to highlight is from South Sudan. And I think it's interesting and was highlighted yesterday that actually the humanitarian and emergency response space was one of the first to really take in the need for menstrual health programming. And at that stage, it was very much framed in a sort of dignity kits and providing products and things to people who are in situation in camps or displaced situations. And that's obviously got its place. And there is such an importance of responding to the needs at the time. But as I say, also trying to think, okay, how do we ensure that there's a sustainability element here? How do we ensure that it's community-led? And so I think what's really interesting to highlight from them is how that they've worked to also create community champions, as it were, local people who work in those communities and often particularly men. And you can see from this photo that it's actually a female trainer working to build up a group of male champions who can then have involvement and understand the situation that some of the women that they're around are living with and how they can best support them. And also ensure that when those men are carrying out broader trainings around wash facilities or hygiene or broader health messaging, that again, they're equipped to be able to talk about menstrual health and understand the needs of the women that they may be speaking to. So that's a very brief overview, but I think for me, the real 3 key points, as I said, was we have to be multi-sectoral. We have to think how menstrual health interplays. We also have to ensure that it's demand-led, that we're listening to the grassroots, crucially that we're funding directly the grassroots. They're the ones that understand the issue and how to carry out those interventions in their places. And finally, that there's a long-lasting and sustainability and environmental impact element. Thank you very much.
Thank you, Alethea, so much for that research and what you've shared with us. There's an interesting theme that's been strung along as we've been talking about this through the different presentations, is to have it be community-led, to listen to the beneficiary. When we integrate menstrual health and SRHR, we have to listen to what's happening on the ground. I also really appreciated the point that you brought up, that we have to identify and call out menstrual health specifically, that even though everybody wants to do it, if it's not a line item in the budget, it could get lost. And so I really appreciate that you brought that out. And I think as we go forward, as we work in integrating, those are things to be aware of, as well as working with all the other different sectors in that. I wish we had another hour that we could spend together to get the questions and then hear from everyone the answers that they shared. But I feel like it's been a really rich discussion, and it's such an exciting time as the theme for menstrual hygiene is it's time for action. It really is. We have that new technical book that we can look to as a guideline. We have our new menstrual health definition. We've heard of what the research is saying, that as we include menstrual health in the SRHR, there is an uptake in other services that come, and we need to be aware that we don't get lost as we do this, as we integrate, that we make sure we do specifically have a line item budget for the menstrual health. And to have it be sustainable, we really have to have it be locally led, listening to the people on the ground and having them make the decisions, giving them the right to choose how to self-manage themselves for self-care. Very important. Thank you so much, everyone, for all you're doing, for all the different organizations and governments that are supporting and helping ensure that the needle is met is moving forward in menstrual health. Continue in the rest of the sessions. Have a great rest of your day, and thank you so much to everyone for your help and support.
Thank you, an incredible plenary indeed. Now please, ladies and gentlemen, give our moderators and speakers a virtual round of applause. That of course brings us to the end of this session. The marketplace will be open from 3 to 3:30 South African Standard Time, and we have 3 fascinating concurrent sessions starting at 3:30. Now I'm sure you know how this works by now. Just click on the buttons on the left and go to the room of your choice. Enjoy your day, and don't forget that tomorrow starts at 12 South African Standard Time with a country-led session from Uganda, which will be taking place in the concurrent session room. See you then. We close the session with the performance from Zuhura, the African lioness. Enjoy.
Bodily ritual. We paint in red. This is our ritual. We do it without fail. We remain faithful. The fountain of our color is deep, mystique. We keep it flowing even when we sleep. We paint in red. As we cleanse, connecting with our bodies, we paint with the moon, glowing through every shine. Every time we bleed, a new life begins. We paint in red, Even when our colors spill on the wrong canvas, even when we cannot afford a canvas, we paint in red. Even when our lips are tied so we cannot share the pride of our paintings, even when our feet are hurting from seeking wisdom behind our art, or when they lie and expect us to cry, we paint in red. Because we believe in the ritual. We paint in red, even when our ritual is shamed, even when they fear this ritual to be named, we paint in red. Paint our bodies every moon and glow through every shine. We rise and paint in red to express desire, love, passion, and our fire. We paint in red, we celebrate our flow, our colors, for we are a work of art. We are women, healthy, beautiful, and alive.
Yango Bageri. Bageri.
Vamos a